All right, good afternoon and welcome. My name is Meg Beyer. I'm part of the Managed Care Technical Assistance Center team, otherwise known as MCTAC, and I'm really happy to be joined by some of our OMH partners today for our webinar this afternoon on COVID-19 program and billing updates for Children's Day treatment programs. So a few logistics before we get started and dive into things. We are recording today's webinar, and we'll be sharing both the recording and the slides shortly. They'll be posted to the MCTAC website, and for folks who are on this webinar today, you'll be able to share these recordings and slides with your colleagues or staff members who might not have been able to join, or just refer back to some of the content that's shared within the slides and recording. We do have a brief period of time for today's webinar, so we are asking you to, as always, chat in your questions. MCTAC is collecting them in a centralized document, and we hope to have time at the end to answer them. But if we don't, just so you know, all the questions that do come in will be shared with our OMH partners who are joining us today. So as time permits, we'll try and get to as many questions as possible, but just knowing that time is more limited this afternoon, if we don't get to your question, please know that it will still be shared with the state so that they'll be able to review it as well. And finally, I just want to thank all of our OMH partners that have joined us today. And I want to thank in particular our presenters, Donna Bradbury, Peter Barnett, and Gwen Diamond, who will be presenting. And I also want to thank all of you for joining us, and my colleague Caitlin, who is running things on the back end, is our WebEx wizard and making sure everything operates smoothly today. So with that, I want to thank you all again for joining and ask Donna if she would like to start us off.
Thank you, Meg. And thanks everybody at MCTAC for hosting this webinar. Welcome everybody and good afternoon, and thanks for joining us for this webinar on program and billing updates for Children's Day treatment programs. We'll be going over program expectations, documentation changes, and minimum billing standards during this disaster emergency. Next slide, please, Caitlin. So first, thank you. Thank you all for providing services for the most vulnerable children and families in New York State. And I'd also like to just take a moment to acknowledge you and the reality that you yourselves as providers and your staff may actually be experiencing feelings of grief and loss and sadness during this emergency. And so I just want to take a moment to recognize that and encourage you all to provide good self-care for yourselves, because in doing that, you're better able to care for others. Next slide, Caitlin. So just a little background that some of which is fairly obvious, right, that New York State is in the midst of a crisis and that you as behavioral health providers offer a critical safety net for New Yorkers at this time. In fact, you've never been more important. OMH has been and continues to be working closely with the Department of Health and the Governor's Office to secure waivers that will allow providers to deliver services in new and flexible ways, including through the expansion of telemental health. And we'll be talking about more of this as we go through the WebEx. The program and billing guidance that you'll be hearing about today was issued on April 13th of this year and is effective at the start date of this declared disaster emergency, which is March 7th of 2020. So OMH's vision here and intent is to maintain high-quality services and continuity of care for all program participants, as well as to support agencies and providers in maintaining their current staffing levels. Behavioral health providers should strive to provide a level of service, care, and support consistent with historic levels provided. And the intensity and frequency of service delivery should be appropriate to each individual's needs. All providers should be continuing to support individuals' unique goals during the crisis, and we recognize that original treatment goals may well be superseded by new goals that are more immediately relevant to the coronavirus crisis. OMH also expects providers to utilize telemental health whenever applicable and to make every effort to provide as much service as is needed by the individual. Next slide, Caitlin. So, essential service delivery. Essential services are a core set of services that must be provided throughout the disaster emergency based on individual need and practitioner scope of practice. Delivery of essential services does not require an update or revision of an individual's treatment plan. And as always, services are to be person-centered, flexible, and intended to support the individual's basic needs at this time. Some examples of essential services include medication assessment and prescription, counseling and therapy, crisis services, and very important at this time is dissemination of information relative to the COVID-19 disaster. So in terms of program expectations, this language that you see on this slide is taken directly from the guidance document that's posted on our website that hopefully you've seen. Programs must make a minimum of 5 telephonic outreach efforts to every enrolled participant each week, so that's at least 1 per day. Programs should continue efforts to engage those participants who are difficult to reach, and all outreach efforts must be documented. The primary purpose of the contact is to engage the individual, either the child or youth or the family or caregiver, assess needs, and provide support. Also, it's critical to ensure that each individual child or youth or family member has a list of important telephone numbers, local resources, and a step-by-step plan for contacting appropriate stakeholders when needed. And for individuals receiving services from a psychiatrist or a nurse practitioner, Medicaid management must be provided at least once per month, and this can be done telephonically. A few more points before we move to the next slide. Just keep in mind with children and families that the current crisis has surely increased anxiety and social isolation for many, if not all of us. And for our most vulnerable populations, this could mean a need for increased intervention. Try to remain as connected as possible to your children and families, and don't ever underestimate the power of your outreach and connection. Be aware of how critical your role is, and be creative in your outreach. This is an opportunity to engage families and maximize your clinical impact. And certainly I've been hearing wonderful stories from the field about how creative you've been as providers, and I truly appreciate that. If you continue your group interventions, if you can do that, please do so, or even initiate a new group that may involve parents, which can decrease isolation and increase the connectedness for families. You can always take a few minutes with children and families to review healthy coping skills. We all can use those reminders. You can offer opportunities to prevent conflict in the home, such as creating and following a schedule, ensuring regular bedtimes, and also encouraging families to set aside time to have fun and to play. This is a wonderful time to revisit crisis plans with children and families, encourage families to identify key supports in their lives, and note that those supports may have changed since this crisis began. So revisit that concept often. And a final note that applies to all of us, ensure that families are practicing good self-care, like eating well, drinking enough water, getting exercise, getting enough sleep, and finally, being kind to yourself. And I say that as just as a reminder, again, that as providers of service, as therapists, as clinicians, as leaders, we all need to practice good self-care. So next slide, please. So changes in documentation requirements. For existing recipients during this disaster emergency period, again, effective March 7th of this year, or until and ending at the end of the emergency period or until such time as supplemental guidance is issued, treatment plan reviews are not required and may be postponed as needed. Providers may work under existing treatment plans and provide additional services as needed to ensure continuity of care and address mental health needs related to the disaster emergency. The need for additional services which were not already documented in the treatment plans should be documented in a progress note and approved by a physician at the earliest practical time during or after the emergency period. Next slide. So just a note here that in terms of children's day treatment, OMH's expectation is that new admissions are not necessarily going to be happening due to the fact that school districts are closed. I do want to note that we recognize that admission to children's day treatment is dependent on the committees on special education and district referrals. And we are at the Office of Mental Health in touch with state education leadership. And if this policy is to change, we will be notifying you as providers as soon as that changes. But right now, we do not expect day treatment providers to be accepting new admissions. Next slide. So providers at this time may suspend their internal written utilization review procedures as required by OMH regulations for the duration of the disaster emergency. It is our expectation that this process will resume once the disaster emergency is over. Next slide. Okay, so program expectations and billing requirements. The new guidance establishes program expectations and a reduction or elimination of minimum billing requirements for specific children's day treatment rate codes. These are to be used for billing during the disaster emergency or until such time as supplemental guidance is issued. And this new flexibility in service delivery and billing are not intended to establish lesser standards for provision of services and support. So with that, I thank you again, and I'm going to turn this over to Peter Barnett. Peter?
Thank you, Donna. My name is Peter Barnett. I'm with the Office of Strategic Finance here at OMH, and I'm joined today by Gwen Diamond, and we're going to walk you through the billing changes under this revised guidance in brief. I want to emphasize that the release of the billing guidance, which reduces the contact standards for children's day treatment, is intended to stabilize provider Medicaid revenue during the disaster emergency, where obviously the rules for contact and program participation have been sort of turned upside down. It's our intention that these measures will help sustain historical levels of revenue, stabilize staffing levels, and the capacity to continue to serve kids during these really extraordinary times and as we come out the other side. So during the declared disaster emergency, which again I'll emphasize these billing guidelines are effective March 7th, providers can use a full day rate code, which is rate code 4060, for any contact with the individual of at least 5 minutes. And then as Donna noted, programs should be making outreach attempts daily for program participants. And if an outreach attempt is unsuccessful or contact is less than 5 minutes, providers will still be allowed to bill the half-day rate code, which is rate code 4061. If there's no direct or telephonic contact with the client, program should include clear documentation of the outreach attempt in the client record. Contacts with collaterals are also reduced to the 5-minute minimum standard, but the collateral rate code should be used in that case. That's rate code 4066. And then if I may advance to the next slide. It's important to understand the requirements for billing modifiers for both the telehealth and the claiming under this disaster emergency standard. These modifiers are required to be on the claim. So we've got a few examples here. If a service is still delivered on-site and existing minimum requirements have been met, then there's no need to use a GT telehealth or a CR, which is the disaster modifier. If a service is delivered via telehealth and the historical minimum requirements are met, then you would add the GT or the telehealth modifier to the claim. If a service is delivered via telehealth and the existing or historical requirements have not been met, but the minimum 5-minute standard under this COVID-19 flexibility guidance has been met, then you would add both the GT, the telehealth, and the CR, the disaster modifier, to your claim. I think for day treatment that the program codes use a GT modifier for telehealth, but we have posted a reference document on the OMH guidance on COVID-19 webpage. That document is entitled Telehealth Modifier Use for OMH Licensed Programs, and a link to those to that guidance page is included in the guidance document itself, as well as this webinar. So if we could advance again, I'd like to highlight that we're on the next slide providing a mailbox for additional billing questions. We have resources available to help you if you have more specific questions, or if you have questions that aren't answered during this webinar, please submit them to this transformation@omh.ny.gov mailbox, and we'll be trying to get through these questions and get your answers as quickly as possible. So I think at this time we're going to reserve the balance of time for any questions that participants can chat in, and I'm going to turn it back over to Meg from MCTAC to moderate those questions.
Great. Thank you so much, Peter. And thank you to everyone who's chatted in some questions. They're still coming in, which is great. I'm going to start from the top, and we will see what we can make our way through. And as always, if there are questions that the state might need a little more detail to, or might need to take things back for, we'll mark that down, and when we send these back to the state, they'll have note of that as well. So we'll do our best to get as much of these questions answered as possible. So our first question, this provider is wondering if outreach can be done via email, as not all of our kids have their own phones, and some of our parents are working during the day. We have had some luck getting youth and parents on the phone. If we can outreach by email and schedule a time to check in.
So this is Donna. So my understanding is that email can be used but cannot be counted as billable time. So if the question is about outreaching for the purposes of setting up a time to talk either on the telephone or via a video connection, that is acceptable, but it can't be counted as billable time. I'll defer to my colleagues to verify that.
Yeah, so it certainly, this is Peter, it certainly couldn't be billed as a full day rate code, right? I think we'll take back the question about the definition of an outreach attempt and whether or not email can be used to satisfy documentation for an outreach attempt in the record, because it is our intention to reimburse the half-day rate where there's an attempt made to contact the client. So we'll provide a clarification as to whether or not email as a format would qualify for that half day.
Thanks, Peter.
Okay. Thank you both. Our next question, This provider is wondering what the best way would be to handle families who specifically ask not to be contacted daily due to feeling that they're being bombarded with teachers, school counselors, speech, other support systems trying to reach out numerous times weekly. And I guess they're asking, is that acceptable if the family asks not to be contacted daily?
So I can understand that, and as a parent myself, with two children, one of whom is in high school and is actually rather busy, right, keeping up with schoolwork. I think what my suggestion would be for that scenario, in order to get your billable contacts in, would be to engage with the parents in a discussion around how to manage, right, that busyness. And in fact, that management of busyness could become a subject of the therapeutic work. And keeping in mind that these children and youth are children and youth with special needs that had previously been sitting in a very specialized educational setting with therapeutic supports, and presumably those therapeutic supports are still needed, right? Even while the children are having their educational piece at home remotely. So my suggestion would be to actually therapeutically engage with the family on a discussion regarding that busyness and how to manage it. And maybe there's a way to schedule the contact in such a way, the therapeutic contact in such a way that it doesn't feel intrusive or like a burden to them.
Thank you, Donna. A question along kind of like somewhat similar lines, but slightly different. So if the provider connects with the individual 4 days in a row for the minimum amount of required time, the minimum amount of minutes, and the fifth day, the staff member is sick, so the call is not made, are there any billing implications for not hitting the minimum amount of outreach?
So I don't know, Peter, how would you answer that?
Yeah, so I think the provider's asking, they're saying they've made contact daily for 4 days and they've met these revised minimum standards, so they should be able to bill for their full day rate for those 4 days. But if they were unable to make an attempt at contacting the client on the 5th day, then we would not expect them to bill for a half day on that 5th day.
Okay. Thank you for that. Someone is looking for clarification around what the state means by individual. Does this mean just the client, or can a 5-minute contact with a parent count to bill the full day rate?
I think we addressed the contacts with collaterals are also reduced to the 5-minute standard minimum. But they would be billing under a different rate code for collateral, which is the rate code 4066.
Great, thank you. Okay, this is another kind of related to collateral a bit. Is the day rate code only applicable for our operating hours during the school day, which is 8:45 to 3 p.m., or would contact after that time be considered collateral?
So just for clarity, the question is, does the time of day matter? Is that the question?
Yeah, I think so. So they're asking, does it matter? So from 8:45 to 3 p.m., that's the day rate code only, and is after that, would that be considered collateral, I guess? Would contact after that time be considered collateral?
So from a programmatic perspective, in my mind, the time of day doesn't matter. But Peter, we don't offer guidance specific to the time of day, do we?
No, I think the programmatic perspective probably is more important here, but I'm not aware of any limitations based on, on the school day or other time of day in terms of the dropping the reimbursement claim. So I think that would be okay.
Okay, thank you, because I think that it could potentially go a long way towards solving one of the problem that was voiced in one of the earlier questions about sort of the busyness aspect, right, and being bombarded. And so certainly from a programmatic perspective, I would be in favor of flexibility so that if it's better for either the family member as collateral or the individual youth or child to meet, to have that contact later in the day, I think that would be fine as long as it's mutually agreed upon and convenient.
So we've gotten a couple questions about what suffices for HIPAA-compliant telephonic contact. And so I think a couple folks are wondering, what are HIPAA-compliant telehealth platforms? Would something such as Zoom or Google Classroom suffice for telephonic contact in a HIPAA-compliant sense?
This is Gary Weisko. I just want to jump in here on this one. CMS is not enforcing HIPAA-compliant platforms at this point in time, and the frequently asked questions that we have on our website addresses this, but there's a lot of flexibility. If you have cell phones or other technology, FaceTime, all of that is usable at this point from a federal and state point of view, as long as it's a clinically appropriate method for communicating with the individual.
Thanks, Gary. And I summarized, I know a lot of folks had like a variety, that's like an amalgamation of many, many questions that came in related to that, so I just wanted to acknowledge. And I thank you, Gary, for pointing out that there's additional guidance and FAQs on the OMH website that kind of goes a little bit into more depth on that. Let's see here. I'm trying to find one last question. We've gotten a bunch. I'm trying to find one that we haven't really touched the subject of just yet. Okay, let's see here. All right, so for day treatment, we will bill for education, which makes up the bulk of full day or half day, and then the clinical services. Are we still billing for education, or is there another way to bill for full day and half day?
So, so this is Donna. I would like whoever asked that question actually to direct it to state ed, but I will do the same. I think we should both reach out to state ed with that question so people know that day treatment is a duly licensed program. State ed licenses the educational component. We license the therapeutic component, and the billing for the educational component is under the auspice of state education or DOE if it's in the city. So I will certainly do that outreach, but I encourage the provider who asked that question to outreach as well.
Okay, thanks, Donna. And just to like add on to that, someone also chatted in, are teachers' notes that are focused on behavior and the emotional state of the child included in the full day along with clinicians? I don't know if we might need more context for that, but.
Yeah, I'm not sure what the question is there, yeah.
Okay. So if that person might be able to just clarify their question, we'll be sure to include that when we send these off to the state. And I know our time is running short, so I want to see if there are any other details that the state wants to share before we start to wrap up the webinar. All right. Well, I want to thank our state partners for leading us through the webinar today. I want to thank my colleague Caitlin for making sure everything operated smoothly, because that is not a small feat. And I want to thank everyone who joined and chatted in their questions. I know there were a number of you who chatted in questions that were not directly answered on this webinar. And I'm sorry we didn't have time to, but just know that all of those questions are going to be sent directly to the state. So they'll be able to see everything that did come in, and they'll be able to follow up if they have the answers and whatnot. So again, thank you, and look out for the recording and the slides that will be posted and circulated shortly.
Great. Thank you.
Thanks, everyone. Yeah, thank you.